talk about what you do in winter, you've got to talk about what you do in summer as well, and you probably have to talk about what you're planning to do over a number of years to prepare to manage demand in future years. And some of the reasons that we recognise that you need to do that is certainly our primary care workforce is ageing, and we're going to have a significant gap in general practice workforce which will occur starting between 5 and 10 years' time and will persist for 10 to 15 years because we've had a dip in people going into general practice. Now, we seem to be recovering that and having more people come into general practice who are younger, but the younger workforce is not as keen and working as hard and long in general practice as what the existing main body of the workforce is. The other thing that we're all experiencing is that patients are getting older, they're having more chronic disease, and in primary care terms that generally means they take more time. And of course the population is growing faster than the workforce is. I thought this was worth having a little look at, which is odd because I think I'm one of the first people to put up kind of secondary care data and I'm the primary care person. But what I wanted to highlight here is that there are 3 purple bars against the blue. And now the 3 purple bars are the areas that my organisation works in, so what we do relates to the 3 purple bars. But I wonder if there aren't some themes associated with the 5, or at least 4 of the 5 lowest bars there. And I think some of the services that I will talk about certainly exist in Canterbury. I'm less clear on whether they exist in Capital and Coast, but I wonder if there's some sort of a thread there, which I'll allude to a little bit more later. So I thought I'd divide up what we do in terms of our acute response and our planning to prevent the need for an acute response. So acute response in primary care in Auckland has what we call POAC, and this is an acute response to acute need. There's a really simple premise, but first of all, what you can see is that actually POAC experiences the same kind of winter peaks. So for those of you who don't know what POAC is, it's Primary Options for Acute Care. It's an incredibly simple premise, but what it effectively says is if as a general practice, and in fact actually as an ambulance or as an A&M centre or even as an ED, you come across somebody who you think, I'll use the general practice example, but you think you're going to refer them to emergency department, we just ask you to stop at that point and ask yourself, what is emergency department going to do for this person? And if you think you know what that is, and if you feel clinically competent and confident to do that thing, then just go ahead and do it and send the bill to us. And so it doesn't actually matter, and this will be a strange thing for you to hear, but it actually doesn't matter whether clinically the person needed to go to emergency department, because I'm sure, as you all know, many people who turn up in emergency department didn't need to be treated there. What matters is that you genuinely were going to send them there, for better or for worse otherwise. And if we can interrupt that flow and change that flow, then we can have a significant impact on who turns up at emergency department. Now, I know this runs in Canterbury because we copied it from Canterbury. But we copied it from Canterbury about 15, 16 years ago now and have been running it ever since. So we run about 25,000 cases per annum. We could certainly do more. And we could do more both with more cooperation from DHB funders, but also with more emphasis on data sharing and understanding potential for variation in the use of the program. But we manage at least 85% of our cases without attendance at ED, and this program's been evaluated 3 or 4 times over its 15 years, and our current estimate is about 1 in 2 of the people we manage would have otherwise ended up admitted. So 85%, well actually 100% of them would have ended up in emergency department otherwise, 85% of them don't end up in emergency department, and about 50% of them would have otherwise been admitted. So we take referrals from GPs, A&Ms, St John's. We also take diversion from emergency department, and we also take early discharge from hospital. So we use it like some of you might have a rapid response type system, and it operates a bit like that. We also have, and this I think is probably where Capital and Coast kind of fits the bill as well, we have a pretty comprehensive regional after hours network, and I suspect that plays a part in a lot of the urban, heavily urban DHBs having slightly lower rates of ED use than some of the rural DHBs. Our regional after hours network is cooperative in that people work together. It's organised, it's got a consistent communications plan which comes from the DHBs, the GPs, the after hours clinics, and a really important component of it for us is the after hours triage lines, home care medical. So we also worked cooperatively to identify target groups where we need to subsidise after hours consultations to help stem the flow of people into emergency department, which is free. So through the after hours program, significant groups of at-risk people, so quintile 5, over 65s, under 13s, generally won't pay more than a daytime co-payment rate to be seen after hours through the network of after hours clinics. I did mention the National Telehealth Service and Home Care Medical, and Alexandra is here, and so if anybody's got questions, Alexandra is the Clinical Director of Home Care Medical, so if anybody's got questions about that, I'm going to throw them to her. But aside from running the National Health Line and a terrific range of other related lines, some of which will contribute to acute demand at the hospital, especially the mental health lines and chat rooms and things that we run, it also runs general practice after hours for most of New Zealand. And for some reason I seem to have, no I don't, I do have the right slide. So the after hours line means that a phenomenal number of GPs, when they close, they switch their phones over to Home Care Medical, and when the telephone calls go through, they get answered by a nurse who answers them in the name of the practice. And we're currently running at about 93 to 95% of the calls to general practice after hours being managed through the call centre without them being referred to a face-to-face service, at least until the next day. We've also done other things through the Telehealth Centre, which is an important one was a project that we did with St John. Good to see so many people from St John in the room today. Where we joined up the call centres from St John with the call centre from Home Care Medical and passed over grey calls, so calls where there's a possibility that we could manage them without sending an ambulance to the nursing line, and we ran that pilot for a year, which I think finished at the end of June last year, and through that in the Auckland region we believe we avoided about 6,000 ambulance transports to emergency departments in the greater Auckland region. So these are some examples of an acute response to acute demand, interfering with a normal journey of somebody who is acutely unwell at the time. But I suspect probably the bigger area is how you plan for preventing this at a much more strategic level. And Kiriana talked about tree management and forest management, but I think I'm going to talk about leaf and twig management. So we have here what we call a planned proactive care response, which is actually most advanced in Counties Manukau region. And I don't want to belabour this model, but key components of the model are actually trying to identify the people who are going to go bad, if you like, or are going to have an adverse event in a known period of time in the reasonably foreseeable future. And I think, Carol, you talked about some of this from a disease perspective with COPD and CHF. We've taken a slightly different view. We trialled those things and we did find COPD very successful, and we also found CHF successful. We found it so successful that we simply tried the same model on anybody who turned up to emergency department twice or more in a 12-month period, and we found that was pretty successful too. And I think it's because we didn't really take a very disease-centred approach to our treatment path. We take a much more person-centred approach to our treatment path than a disease-centred approach. So it begins with identifying people at risk, and if you have to wait for people to turn up to hospital, then you've definitely, by definition, missed the first opportunity to avoid an event because one happened. So we now run a risk stratification algorithm, and our risk algorithm allows me to create a number, a percentage risk of the likelihood of an acute hospital attendance in the next 6 months for all 800,000 people that are enrolled in ProCare. So I can look at a list and I can tell you the person that we believe it is most at risk of an acute admission through to the person in number 800,000 who is least at risk of a hospital admission. And so this is what I mean by leaf and tree management. So we can send a list of named individual people like Donald Duck and Mickey Mouse to named clinicians with an estimate of their likelihood of a hospital admission in the next 6 months. And based on that, we can then create a care plan with people which addresses their goals and aspirations, and we support that with a package of care, which is basically an aliquot of funding that allows the practice team to set up whatever is necessary to implement that care plan over the period of about 12 months is what we use to try to normalise a new set of behaviours and a new confidence in people. Now what's really important, and this is something which Carol mentioned, that Canterbury are unashamedly interested in reducing hospital acute demand. To a reasonable degree, we agree with that. Certainly at our alliance table at counties, we are unashamedly pursuing exactly the same goal. But to get to that goal, we cannot tell people that the reason that we do this is to drive down hospital admissions, because it's not really that interesting to people who have never had one, and it's not actually that interesting to general practice either. So what we want is to instill a sense of confidence and independence in individuals. So our goal is not to unenroll people from this program, our goal is to graduate people from this program with a new sense of independence and confidence to manage themselves. And in keeping with previous speakers, has it worked? So we think it has, and we think it has because of this. This is a self-management capability index called the Partners in Health Scale, and this is all about people's understanding of their conditions, their confidence to manage their conditions, and a whole range of things. There's 13 or so questions in here. And you can relate this to a whole series of other indicators and evidence to say if this shifts, other things will shift. So we're using this, I guess, as a process measure, but where its beauty lies is it really doesn't matter what your condition was. It only matters that you were at risk of hospitalisation, and you are now, through this program, an awful lot more confident in looking after yourself. Now, we can show a link between confidence in looking after yourself and in reduced use of hospital and actually any health services, which is good for sustainability of the whole health system. Now, you may or may not believe me on that, and we would certainly love to have the hospital utilisation outcome data to support that, which we don't have yet, and we may never have, and I can give you some reasons why I think that exists, which won't mean that we haven't had an effect. But you might be more interested in this. So this is when you take that concept and then you break that down into the subset of people in that cohort. And ProCare has 9,000 people who are in that program, at-risk individuals at the moment, out of our population of about 250,000 in the county's Manukau region. Now, amongst those 9,000, there are 2,000 for whom we have got effectively before and after HbA1c measures for diabetes. And the simple message in this graph, if you can follow the graph, these are HbA1c levels across the bottom. In this region, we consider anybody who is under 64 to be in okay control. We'd like it to be lower than that, but what's important is that the blue graph represents a shift to the left from the orange graph, which means that in general people are getting better. Their glucose control is much more under control. So there's a 6% increase in the fraction of people here who are less than 64 in there. Now that's against the backdrop, if we look at 9,000 people who have diabetes in the who we've got before and after measures on in the Auckland and Waitemata DHB regions, where only 2% of people moved from being greater than 64 to being less than 64 over the same period using the same indicator. Now, this is only 2,000 people in counties out of a lot of people in counties that have got got diabetes. But if you look at all of counties, the impact of this move for this group means that their population, instead of moving by 2%, moved by 3%. So it was 50% better than the Auckland Waitemata experience. Through identifying people and targeting them with a successful intervention and producing a thing which has an impact at a whole population level. Look, there are 1,000 things that you could do, but if there were two big things that I would do, the first would be that prediction and setting people on a path to independence. The second is I would look at the capacity of general practice, because of all of the reasons that we talked about at the beginning of this, the winter peaks, the changes in workforce, the changes in patient load. And it's great to have Damien sitting at the front here, because I'm about to plagiarise all the stuff that I learned of him and people in Midlands. We are aware of a thing which we call the healthcare home, which is based on primary care medical homes or patient-centred medical homes in the US. And the Midlands area has done a phenomenal amount of work on this, as has the Canterbury area, and ourselves and Compass in the Cape Coast area are starting to get involved in this, where we know there are good evidence-based models where you can take an existing New Zealand general practice and you can reconfigure it using models of care and using business efficiency tools, changes in workforce, and you can produce a 25 to 30% increase in capacity to interact with patients within essentially the resources that the practices already have. So that's quite, from our perspective, that's pretty phenomenal. That gives us quite a major boost. The problem is, for us, that effectively the funding model that we operate under wouldn't buy any use of that 30% of capacity. And so the opportunity here is to create that capacity and then to jointly deploy that capacity across primary and secondary care to produce a much more sustainable improvement in capacity for the health system. So again, there's a certain amount of evidence. This is not mine. This is a review of evidence which actually has been put together by Network 4, which is 4 PHOs in the largest PHOs in the country. And what you see is across a number of domains when you review 28 studies, a pretty consistent thing where you get improvement in finance, improvements in utilisation, improvements in quality, improvements in access, improvements in satisfaction. And depending on what type of study you look at, so these are peer-reviewed studies, so this is more research-oriented, this is government evaluations of programs they've put in, and this is industry reports. They show reasonably consistent pictures of improvements in all of those domains. So we're reasonably confident, and in terms of not wanting to reinvent something, we're anxious to try to implement this across as much of the country as we can to produce that kind of increase in capacity, because we think that will help contribute to managing demand. That's really all I had to say. I mean, I know there's a host of other things we could have talked about pathways, could have talked about a range of other things, and I'm here all night. Enjoy the chicken.
Thank you. Any quick questions for Mariana and Paul for the presentation? I've got one that I want to pick up with you afterwards, because I've seen that kind of example of the people that risk of readmission used quite a lot in the UK and not so much over here. And what was really interesting is, as you said, there's remarkable accuracy around the algorithm. Where it tended to fall down is how people had implemented it. Yes. And who implemented it and who took that information and when and how they used it and what they did with it. And that was where people really struggled, because they just went, well, we know these numbers, but we don't know how to handle it.